All right, today's topic, group beta strep. GBS, it's one of those topics that every pregnant mother has to consider at some point. It's one of the tests that many women dread. So what's the deal with GBS anyways? So group beta strep is a bacteria that's normally found in our flora. An infection occurs usually in those who are susceptible for whatever reason, be it frequent use of antibiotics, a lowered immune system, lots of sexual partners, history of UTIs, for example. And so why do we test for it in pregnancy? So we began to test regularly for it because some babies born vaginally to GBS infected mothers, not simply GBS positive, but those with an infection, may become sick from the GBS infection. So signs of GBS infection in the newborn include flaring of the nostrils when breathing, like that, grunting or wheezing when breathing, or seesaw respiration, so alternating the chest and the stomach, and it's quite pronounced, usually you can tell, which these three together signify respiratory distress. And then along with mood changes, irritability, fussiness, changes in color, babies will get a distinct like white, gray, pale, weird sort of look. It's not the same as cyanotic, which is like a lack of oxygenated blood, so usually bluish kind of is cyanotic. But there'll be kind of a distinct white-gray color. Changes in nursing as well, and fever comes on as a later symptom, as well as changes in tone. So hypertonicity, so like extra tone in the muscles, or increased tone will be associated with irritability, and then hypotonicity or lack of tone, so more floppy, is associated with lethargy. So do all babies really acquire this and quickly become sick simply from traveling through the birth canal? Some think that babies get sick from GBS infection in utero rather than through birth prior to the onset of labor. So that the GBS bacteria is traveling up to the uterus and infecting the baby before, or causing the problems before the actual birth. So as well, the idea that the test results are accurate for 5 weeks, and typically around here, I think, and in the States, often mothers will be tested for GBS at around 24 weeks as the earliest I've heard, or up to 36 weeks, I think, is usually the cutoff that they want you to have it done by. And they say that the test results last for 5 weeks. I could be wrong, but I think that's typically kind of what's accepted. And this is due to a single study that was done on just over about 116 women, I think. And larger studies have not been able to replicate those results, and even show that the cultures of the swab may not be reliable for even 1 day, so 24 hours. Then we also have the issue of penicillin-resistant GBS, which is becoming more and more of an issue. And apparently about 50% of GBS is resistant to penicillin and would require a stronger antibiotic, which has greater side effects. According to what I was learning this week, also another consideration is that a GBS vaccine apparently is never going to happen because of how quickly the surface antigens mutate, and not to mention the fact that the liability with giving an experimental vaccine to pregnant women is too great to be pursued, or at least it should be considered too risky, and there's lots of ethical issues there. And then something else to think about is the fact that GBS is 2 times more prevalent in places that overuse antibiotics. Another thing to consider is that GBS positive babies of antibiotic treated mothers had more incidents of flaring, grunting, respiratory distress than babies that were colonized with GBS but didn't get treated with antibiotics. So there are so many unknowns about the real science behind GBS and the newborn disease from GBS, and there are a few questions that we might want to think about that we don't currently have answers to. So every vaginal and pelvic procedure, such as catheterization, rupture of membranes, pelvic exams, cervical checks, increased risk of upward travel of bacteria from the vagina to the uterus where the baby is. So with that in mind, since artificial rupture of membranes is a known risk of GBS disease, how would limiting this procedure affect incidence of GBS in the newborn? And another thing to remember, which I can't remember if I've said this on a different video or not, but amniotic fluid is bacteriostatic, meaning it helps to limit the growth of bacteria when the fluid kind of washes out. And typically in most labors, the waters will break kind of in the later stages. Some women have the waters break before the onset of real active labor, which that's kind of a different, it's not a high percentage of women that happens for. So most commonly it ruptures later in the labor process, which gives this beautiful bacteriostatic wash through the vagina and the birth canal for the baby to come out through, which if we didn't do that early and we just let it happen when it was supposed to happen, maybe that would affect the incidence of GBS disease in the newborn. So on kind of along the same vein, how would limiting or eliminating vaginal exams in GBS positive women impact newborn GBS disease? Another question to consider is, what percentage of full-term babies are injured, not killed by GBS disease, but injured, and what symptoms do they experience? So we don't even really know how many babies are being affected by this, and yet we're treating like every woman who gets a positive swab at some point in their pregnancy. And if we assume that GBS positive equals an impending GBS infection and put all mothers on IV antibiotics for this who test positive, which, and we know from other studies that it fluctuates a lot, the kind of levels of GBS in the vaginal flora, it means that she has to then birth in the hospital, have an IV, change the atmosphere for birth, imprint this newborn life with antibiotics, which we don't fully know the effects of doing this to a newborn baby, and have a birth that isn't a fully normal physiologic birth. Is that a fair trade? I don't know. I mean, I guess it's up to each of us. And there's also more risks with antibiotics than we typically like to admit in our culture, and we don't really know what that does to mom and baby in birth, and what the long-term effects of that may be for their immune system, for their propensity for allergies, for their normal gut bacteria, or even if giving these antibiotics is even helpful in reducing GBS incidence in order to justify the risk. So this wasn't so much of a teaching, I mean, maybe it's considered like a teaching video, but more kind of just bringing up some questions that we want to ask around this kind of thing. And I think Wapio shared some, this information came from her. A lot of these questions were coming from things that she was kind of encouraging us to think about. So they didn't all just come from me, but yeah, I think I'm not really saying one way or the other, but I think when you kind of put the pieces together of thinking about what the risks are, what the evidence is, do we even know how helpful something is, it might make us stop and ask for a minute, do we actually need this? And yeah, I don't know. I think asking questions is usually helpful, and especially when it comes to our health and our baby's health and the health of future generations as well, especially when things like bacteria and flora can impact you later on in life and in a lot of different areas of health as well. And yeah, so this video did not end up any shorter than my previous videos. In fact, I think it might be one of the longest ones. I guess I just get too chatty and have too many talking points, but I'll end it here. Thanks for watching. Talk to you later.